It's a great area for a patient with lung cancer on all aspect, early stage, late stage. Of course, we're not there where we want to be, but it's evolving every year, more progress. So for the early stage, and again, talking to be specific about the patients who have cancer without major actionable mutations, this is where the neoadjuvant versus perioperative versus non-surgical approach. It's really in the immunotherapy era how you integrate the immunotherapy. So we have definitely multiple regimens that have shown efficacy and have shown better, outcomes when they were compared with, just simple neoadjuvant chemotherapy followed by surgery. So now we have multiple options. We have the options of, first, if patients, and we're talking about the locally advanced, stage 2, stage 3, if a route is to go through surgery, which needs a multidisciplinary discussion, can't emphasize enough the importance of this, to have the team, multiple team members, surgeon, rad onc, pulmonary, med onc, and of course the patient input and the patient wishes, are very important. But there is a surgical route and there is a non-surgical route. And the non-surgical route, again, if let's say patient is a stage 3, it could be chemoradiation, or it would be chemoradiation concurrently followed by adjuvant immunotherapy, or by consolidation immunotherapy, I should say, that has shown, excellent long-term outcome. If we go on the surgical route, this is where we have the good problem, or the good dilemma again, is do we do neoadjuvant only, chemo and immunotherapy and nothing, and then followed by surgery and nothing afterwards? Or do we do what we call the perioperative, neoadjuvant, chemo, immuno, followed by the surgery, and then followed by immunotherapy for quite some time? These options are not compared with each other. There's a lot of factors which would make us, but where the concern is, are we over treating patients if after surgery we give them more immunotherapy that they really didn't need and they got most of the benefit from that neoadjuvant? Or are we under treating some patients that they're if they only get surgery and we won't continue? We believe there are some patients who benefit from that consolidation or from adjuvant IO, and some maybe they don't need it, and we need more. There are more research and more trial already happening and trying to look at certain factors which patient may or may not. But doesn't take away from the fact that we don't do upfront surgery right now, rarely, for patient with a locally advanced. The neoadjuvant chemo IO is definitely has revolutionized the way we treat these patients. And some patients actually, their disease, we have a pathologic complete response rate, which means percentage of patients who actually they go to surgery, and we still recommend surgery. You remove the tumor and there's actually all dead, all necrotic, and the PCR rate or the complete response, depending on which regimen or which trial, is anyway from 18 to 25%, which is definitely telling us that what we did for them before surgery has helped a lot.